Thanks, Smita. Mahesh?
Yes, ma'am. Good evening, everyone. I welcome you all for this Meet the Expert webinar. And today we have an interesting talk on cerebral pulse mimics by Dr. Brahim Tabarki from UAE. I request our President, Shafali ma'am, to introduce the speaker, the expert for today's session, and moderator for today's session. Over to you.
Thank you. Thank you. Good morning, good afternoon, and good evening. We welcome you all to another session of What Do the Experts Say? And we will be having a very eminent speaker, Dr. Brahim Tabarki, will be talking about CP mimics, which is very, very important. He's consultant pediatric neurology, Division of Neurology, Department of Pediatrics, Prince Sultan Military Medical City, Riyadh, and adjunct professor pediatric neurology, Al Faisal University, Riyadh, and professor University of Tunisia, and he's a lot of publications and a lot of abstracts and invited speakers. He's really an authority in this area. Thank you, Dr. Brahim, for accepting this invitation. And the experts are Dr. Biju Hamid. I think nobody needs, he doesn't need any introduction. Everybody knows him. Next slide. Dr. Aykan, she's head of pediatric neurology department in University of Health Sciences, Izmir, and faculty of medicine, Dr. Behçet Children Training Research Center, Turkey, and has a lot of publications to her credit, and her areas of interest are neurodevelopmental disorders, refractory epilepsy, ketogenic diet, developmental epileptic encephalopathies, and a lot of innovations for individualized and innovative drug development in SMA. Welcome, Dr. Aykan. Dr. Farida Jan is Associate Professor, Head of Department Pediatric Neuroscience and Rehabilitation, Sindh Institute of Child Health and Neonatology, visiting consultant, Lykat National Hospital and South City Hospital, Pakistan. And our areas of interest are drug-related system, epilepsy, pediatric headaches, autoimmune CNS disease, and pediatric behavior issues. Has a lot of publications to its credit. And for moderating the session, we have our very own illuminous Dr. Shruti, who is a consultant pediatric neurologist, now leading her in, she was an alumni from AIIMS New Delhi, but now she is very well established, in Karnataka. Dr. Shruti, all over taken to you.
Good evening, everyone. I welcome all the speakers and the experts to this session, and we have a session on cerebral palsy mimics. So without wasting much time, I invite Dr. Brahim Tabarki to start his presentation. Could you please share the screen, sir?
So thank you very much, and thanks again for your invitation. It's always my pleasure and honor to be with you. So again, I will speak about cerebral palsy and mainly cerebral palsy mimics. So all of us, we are familiar with this common condition all around the world. So cerebral palsy, for us as pediatrician or pediatric neurologist or other healthcare provider, cerebral palsy is a very common condition. So one of the challenging in this is the definition of cerebral palsy or the diagnosis of cerebral palsy, which is most likely based on the history and examination. So it's a clinical descriptive term. And with the advance of more diagnostic tool, mainly in the next generation sequencing and other metabolic tool, we are more and more recognizing a condition or disease that may mimic in their clinical phenotype with the cerebral palsy. And this is extremely important for the patient, for the family, and to decrease the burden of these diseases. So we can provide now more and more target or precision medicine treatment. We can provide more information about the prognosis and about the genetic counseling. So I will go briefly an overview, and I will highlight mainly the scope of this presentation. So if you have a patient with a CP phenotype, what are the red flags to think about any underlying metabolic or genetic or other condition that may mimic cerebral palsy. And I will briefly speak about the common condition that may mimic cerebral palsy. So again, cerebral palsy is common and is 2 to 3 per 1,000 live birth. And even in the last 20 years, there is slight decrease in the prevalence of cerebral palsy, but it's still a very common condition all around the world. And in spite of the improvement of obstetrical and perinatal care, our clinic are full of patients with cerebral palsy. So it's a problem of movement, it's a problem of posture, and as a consensus guideline definition, CP is a developmental disorder of motor function diagnosed in the context of non-progressive disruption of normal fetal or infant brain development. So it's insult very early, mainly in the fetal, or can be in the perinatal period. And as you see, so beyond this motor definition of posture and movement, so cerebral palsy, or most of the patients with cerebral palsy have at least 70 to 80% have a comorbidity, including epilepsy, intellectual disability, visual problem, hearing problem, musculoskeletal, and neuropsychiatric, etc. And this will contribute to the heterogeneity of cerebral palsy and the challenging in the diagnosis, etc. And so it's better to speak about cerebral palsy as a clinical neurologic syndrome, because nothing is specific or neither pathologic or etiologic entity. And even in the last genetic definition or consortium in 2019, so they kept this definition as cerebral palsy is a clinical definition regardless of the etiology, whatever genetic or others. So classically, the classification of cerebral palsy is based on the clinical observation by motor syndrome. And you recognize here the main type, which is the spastic type, whatever, into diplegic, which is the most common because of prematurity. The quadriplegic is still common in a certain area because hypoxic ischemic encephalopathy, and the hemiplegic is the less frequent one in the spastic group, and this is most of the time related to antenatal stroke. So around 80% of our patients are spastic. It can be isolated spasticity, sometimes associated with this dyskinetic cerebral palsy, and in this dystonic group, which represent around 10 to 15%, and the least common one is the ataxic group. Probably the ataxic group is the most challenging in the term of diagnosis and in the term of mimics or with other conditions that may mimic cerebral palsy. So if we look to the risk factor, and this will definitely change according to the place you are practicing. So probably in the developing world, prematurity is on the top. In other many regions, perinatal asphyxia is still very common, causing hypoxic ischemic encephalopathy. But again, we have a multiple risk factor. Sometimes it's combined. So prematurity, which with its complication as PVL or intraventricular hemorrhage is causing spastic diplegia. Perinatal asphyxia can be associated with spastic quadriplegia because of hypoperfusion in the watershed area, or dyskinetic cerebral palsy because of basic ganglia injury. We have also infection, we have perinatal stroke, we have connectors, we have hypoglycemia, we have obstetrical trauma, and many are low birth weight, etc. So very important to recognize the cause of, or at least the risk factor for cerebral palsy. I think it's so we have to highlight very important that I think today any patient with cerebral palsy phenotype must have an MRI. So an MRI is very important to look for the injury, whatever structure or acquired, and if it's normal, we have to put question mark. And it also may help us for the prognosis of such patient. And you recognize here several patterns of patient with cerebral palsy. Just to remind you that MRI is abnormal in 80 to 85%. So in the A, you have a structural problem with cortical malformation. Then in B, you have the sequelae of white matter injury in premature baby. In the C, you have basic ganglia and thalami involvement, and you have in D, very severe cerebellar injury due to severe prematurity and hemorrhage. But if you look down, sometimes even the MRI is challenging. And you have here the first set of slides, a 7-month-old premature baby, and you see the first MRI at 7 months, it was mildly abnormal with maybe some periventricular hypersignal. But when we repeat the MRI later on, you see that the abnormality are more obvious. So I think in today we can say that cerebral palsy not always what it seems because many reasons. Now we have a growing list of disease that especially very early in their course or because they are slowly progressive and because still in many in our region we are still lacking newborn screening or advanced genetic investigation, and thus we can miss those genetic or metabolic disease. And this is extremely important because some of them have precision medicine. We can offer better prognosis for the family. We can offer better genetic counseling. And in final, it's very important for the patient, for the family to decrease the burden, the social, economic burden from cerebral palsy. So let's see a few examples of that. And this is a systematic review of patients with treatable inborn error metabolism less than 5 years and presenting as cerebral palsy. And in the study published in 2014, there is 54 treatable inborn error of metabolism. So another study by another team, almost the same methodology, and found that 150, this is on 2021, and in this study, there is 150 inborn error metabolism amenable to treatment, but presenting as exactly as a phenotype of cerebral palsy. And probably the number is growing every day. And every day we have new genes or a new metabolic disease that presenting with as a cerebral palsy phenotype. So this is a systematic review of the yield of exome sequencing in cerebral palsy. And in this systematic review, the author found a pathogenic or likely pathogenic variant that explained the phenotype in around 1/3 of the patient. And that is, I think this is significant if we deal with patient with cerebral palsy. So what to do? So I think whenever we have a patient now with cerebral palsy phenotype, as we saw in the clinical diagnosis based on the history and examination, we have to put in mind that we have to look for any red flags. And any red flags from the history is extremely important to see if there is a no risk factor for CP. And we saw the common risk factor, whatever prematurity, low birth weight, hypoglycemia, trauma, infection, hypoxic ischemic encephalopathy, etc. So whenever you don't have risk factor, put question mark. So on top of that, so if you have positive family history, if you have progressive disease, if you have regression of milestones, if you have fluctuation of motor symptoms. All these are very important in the history to be picked to help us. Is it cerebral palsy or is it a mimica? From an examination point of view, this is also important, and we know that any dysmorphic feature, any involvement of the peripheral nerve system, of the ocular system, and others, this is most likely not a cerebral palsy. And we have to be extremely careful if you have a patient with isolated ataxia or isolated hypotone. So for those is probably required further investigation throughout other mimics. So that is from the history and from the examination. The same from the MRI. So we said that the MRI is abnormal in most of the case. So whenever we receive a normal MRI or non-specific abnormality, like in this patient with only isolated globus pallidus abnormality and found to be one of the methylmalonic acidemia. So we have a negative MRI or non-specific, we have to put question mark and to revise our diagnosis. So what about, so this is another interesting recently published study. It's a systematic review to identify characteristics suggestive of genetic cause in cerebral palsy. And from this study, so these are the most important key factor to say probably is not. So absence of risk factor, absence of spasticity, the patient have dyskinesia or dystonia, and negative MRI. So very easy to identify these factors. And whenever you have it, so probably we need to investigate more our patient regarding underlying metabolic and genetic tests. So one of the question, what to do? And probably, what we have as a tool beyond biochemical markers. So from genetic point of view, array, Wes, or whole genome sequencing, and this probably will depend on your the available test in your practice. Still Wes is covering a good number. Probably genome is better. And the least one is RACGH. I don't think is helpful in this condition. So the discussion will be between Wes and whole genome sequencing, and it will depend on the available test in your setting. So I will give you a few examples. This is a patient with, so you see this patient with presented with a gait ataxia, hypotonia, and we'll see also the eye abnormality. And it's, so we are familiar with a patient with ataxia telangiectasia, but you see the MRI is almost normal. And this patient have one of the genes, which is ataxia telangiectasia like, which is MRE11A, which is, you can differentiate this. They have also almost the same presentation, but from biochemical point of view, they have a normal level of alpha protein and negative test for ataxia telangiectasia, and it's common in our region at least. So the group of inherited neurotransmitter disorder, this is classically, it's put as a classical mimicker of cerebral palsy, whatever dopa-responsive dystonia or dopa-responsive dystonia-like disease. And we have many types. So this is a classical, what we call the Sigawa disease. And you see the involvement of the lower limb on this dystonia, the upper are normal, the cognitive is normal. And those patients, this is another patient, and she was on wheelchair and considered as cerebral palsy for 10 years. And you see how difficult is the gait. and with a small dose of L-DOPA, carbidopa, around 5 or 6 milligram per kg. Within weeks, the father sent us the video, and the patient is have much better gait. And what is more important, she's not using anymore the wheelchair, and you will see the smile on the face of this patient, how she's happy going to school alone. So in the group of neurotransmitter, we have a CPF reductase deficiency, and there's a family of two. So the first baby, we miss it, and we consider a cerebral palsy. This is a few years ago, and then we have the brother. We presented with these paroxysmal event, looks like a seizure or spasm. We record the patient, and it was with EEG, and it was negative. You see that it's turned to be occlusive crisis, and we diagnose those patients with CPF reductase deficiency. We start on medication, and you see within few months. So the boy is totally normal, and the girl, even we start late, but she improved significantly in the gait and in her cognitive function. So this is another patient who presents this with the dystonia, severe dystonia, and this is from the MRI is easy because we have basal ganglia injury in the and it turned to be one of the mitochondrial disease, and it was considered before MRI as a cerebral palsy. So, and the list is long. So just to tell you about arginase deficiency. Arginase deficiency is the last in the last enzyme in the urea cycle. So in the urea cycle, we have 5 enzymes. Arginase is the last one, and it's present typically as diplegic cerebral palsy. And we know now that we have new medication recently approved for FDA approved for arginase deficiency, which will change completely the outcome of those patients. This is another genetic cause, and you see this is a patient presented to us at the age of 3 years with spastic paraplegia, almost normal in the cognitive function. And this is the MRI, and you see in the A, we have small corpus callosum or thin corpus callosum. In the B, we have a white matter signal around the posterior aspect of the lateral ventricle. And very interesting, the spectroscopy which showed high lipid peak, and this turned to be in DDHD2 spastic paraplegia, which mimic exactly spastic palsy. So I think the example we can give you a lot of example, but what is very important today, I think, that yes, cerebral palsy is still common, mainly in developing country, because we have still hypoxic ischemic encephalopathy is still common. In more developed country, prematurity is common, and those two factors predispose to cerebral palsy. So cerebral palsy is still a very common condition, but in parallel, there is a growing number of metabolic and genetic disease. We have to be recognized early, and I think the easiest way with the history, with examination, and with biochemical testing and next generation sequencing is to recognize, because we have, even they are treatable, we have a very limited window to act and to change the outcome of those patients and to decrease the burden from social, economic, from cerebral palsy. We may have better prognosis, and we may have specific treatment for that. And thank you very much for your listening.
Thank you very much, sir, Dr. Brahim Tabarki, for that interesting and very lucid presentation on CP mimics. I would like to invite our experts, Dr. Biju Hamid, Dr. Farida Jan, and Dr. Aiken Unal, for their expert comments on this presentation, as well as CP mimics. Ma'am, you're not audible. Could you please unmute yourself?
Thank you very much for your presentation, Dr. Ibrahim.
Thank
I
you.
want to say that uric acid is important for the differential diagnosis because molybdenum cofactor deficiency or Lehnihan syndrome mimic cerebral palsy. And I wanted to remember the glutaric aciduria as a mimic of the cerebral palsy too. For that reason, good prenatal history and neurological examination and the follow-up is very important.
I
Thanks.
totally
Thank
agree
you.
with you. Yeah.
So
And
if I
is it-
may take up from there, Dr. Tabaraki, thank you very much for a very elaborate talk. CP, I would say, is still a sore spot for all of us, whether we are in the developed setups or we are in the developing. So going back to the basics, that is, the history is the most important part, as you very elaborately informed us regarding how we have to rule out the positive for the CP, and of course, if those are lacking, then we take the road towards other possibilities. So in our setups, it is rather easy to label them CP because most of the people still do not have the antenatal cares and the natal cares and the postnatal cares. But yes, when you have a high suspicion of index, it always helps. So I personally usually keep a high suspicion, and just like the examples which you have shown, we do get inborn errors of metabolism out of most unsuspecting of patients. So over to you, Dr. Biju.
Thank you. Thanks, Dr. Ibrahim. Very important talk and highlight, and you the definition of CP. I know we've had lots of discussions, and we know that we always remind ourselves of the activity limitation in the diagnosis, and that diagnosis, the consensus definition, still holds very true, because given the fact that all the other environmental factors that leads to CP still exist, not even in the in resource limited settings, but even in resource rich settings. But I think the one key take-home message for me was the fact that you highlighted about the role of genetic testing, and I think that holds true even in a situation where there is a presumed environmental cause. Because even if you look at the recent literature in the last couple of years, the meta-analysis, the systematic reviews and meta-analysis which have looked at genetic causes of CP, and they've put down the incidence to around just under 25%. And as you said, even though the CGH arrays don't add much, but even if you add the copy number variations, maybe an extra 5% will be diagnosed. But I think that this number is still spuriously low, because even if you look at the number of genetic testing that is undertaken in these children with presumed CP, and if the copy number variations are included, if all the children had undergone trio-exome testing, I think the incidence of genetic diagnosis is probably far higher than what we are seeing now. I think there is definitely a strong case for even when there is a presumed cause, all cases of cerebral palsy merit genomic testing. I think we can discuss further on that, but I think that was a key message which resonated to me from your talk.
And yeah, thank you very much. And I think what is also important, we have a growing number of genetic risk factors that may predispose also to hypoxic ischemic encephalopathy. And just a few months ago a paper about CDKL5 and other genes. So even he's not symptomatic for CDKL5, but the newborn is more predisposed to hypoxic ischemic encephalopathy. And this is I think, the interaction, as you said, between genetic environment and other factors is also extremely important. And I totally agree. We are moving more and more to more genetic in those patients. And I think the message is now from our population as a pediatric neurology is clear, but still in the pediatric referral, I think is still weak, and cerebral palsy is still overdiagnosed here as a risk factor.
May I just pitch in? Amazing talk as usual, Dr. Brahim. I just want a clarification. According to you, in which all cases of CP would like a genetic testing? And then I would like Biju's comment, because I wanted to be clear message to go to the attendees of what should be done. See, we cannot do a genetic testing in low resource countries in all of the CP, right? So, I mean, I agree what you are saying, but what should be the recommendation? And, you know, in which situations what do you debate? First, I will obviously, I mean, I'll ask Dr. Brahim and Dr. Biju and the other experts as well.
Yeah. I think we can. Yeah, it will depend on the setting. Yeah. So, and your question is extremely important because we cannot offer genetic, at least now, for any patient. But at least if we divide in subgroups, so we have one group, 100% they need to be investigated if we don't have risk factor from the history, from the examination and from the MRI. So this group definitely should be investigated by more genetic testing. For other groups, even if we have a risk factor, but does not explain 100% our impression. And we now, just a few weeks ago, we have a patient with clear hypoxic ischemic encephalopathy, but the seizure were most predominant and difficult to treat than we expect in this condition, and turned to be another metabolic disease. So this group, I think, should be discussed one by one, but definitely there is one group that I think my impression is all the patient should have genetic testing. Probably for the meantime, WES is including copy number variant is a good test. If we have better, why not?
Hi, everybody. This is Hassan.
Yes, Dr. Hassan, your opinion.
Yes, Dr.
Dr. Brahim, thank you very much. Excellent presentation. I'm really happy about your definition of the red flags for making a subgroup, 3 main subgroup: cryptogenic, non-cryptogenic, and cerebral palsy mimic group. Then we will focus on which group should be investigated with genetic and metabolic testing. Yeah, if we use the red flags for the cerebral palsy definition you explained clearly, we may easily define the group we should evaluate with genetics testing, chromosomal based, or next generation sequencing, or maybe WES on whole genome sequencing. And then I think 10 years ago, we extensively used the metabolic screening for the definition of the metabolic based or metabolic disorders. But I think after the genomic, in the genomic area, we underestimated the metabolic screening. It's also still expensive, metabolic screening for the metabolic based. I hope in the future, most of the cases in the metabolic disorders groups should be investigated with the genetic testing utilities. Do you agree with this? There is a decreasing number of the cases treating with the metabolic screening is also still expensive in the resource limiting countries. What do you think?
Yeah, thank you very much. Very interesting point. I think the newborn screening is still a valid screening for certain disease, and according to the region, which is prevalent disease, at least in my place, now we are screening around 20 disease, and the main expression is at birth, and it's mainly regarding the common prevalent disease. But I agree. So roughly, if today we have around 1,500 inherited metabolic disease around. Genetic, we have more than 1,000 identified, but inherited metabolic disease, we have around 1,500. And if we consider metabolic biomarker, these metabolic biomarker, they can screen only 15 to maximum 15%. So we have 80% today will escape to our metabolic screening. And that's why I think, at least in our region, I think the best is to go through genetics. And if there is a metabolite after that, we can confirm with any metabolite. But I think if we start with our metabolic screening, we'll lose a lot of time, and probably in a good number will not reach the final diagnosis. So I agree that for intoxication, for urea cycle disease, that's easy from neonatal period, etc. But most of the inherited metabolic disease, I totally agree with you. For the limited time we have to act as a treatment, as a window to act, I think the best way, the easiest way, and the fast way is the genetic. Even we have challenging with the genetic sometimes because it's a variant, etc. But I think the best is to go through the genetic and not metabolic, at least in our region.
Thank you. Thank you.
Thank you, everyone, for your expert comments. So there are a few questions in the question and answer section. I would like to ask Dr. Ibrahim to answer these questions. There's this question by Narendra Gamawat. Any diagnostic place of ultrasound drain in neonatal period? Sir, if you could answer.
So I think all of us are neurologists, and the place of ultrasound is very limited. Yes, I agree that the ultrasound is a good tool for neonatologists in premature baby to look for intraventricular hemorrhage. Apart from that, I think have a limited tool. Yeah.
Also, sir, there is a question.
Let me, if I could just add into that, the ultrasound is a very interesting point. Now, recently, as part of reviewing a paper, like I had looked at the recent literature, and it seems that the neonatal ultrasound is the single biggest indicator for PBL in resource limited settings. So it's a very interesting. It didn't occur to me that, but in terms of early diagnosis of CP, early identification of PBL, cranial neonatal ultrasound is a very good tool, particularly in resource limited settings.
Yeah, I totally agree with you. The problem is operator dependent, and that's challenging issue. Yeah.
Also, sir, there is this question, is atonic CP term acceptable anymore? And what about the terms of monoplegic, triplegic, mixed CP regarding anatomical classification of CP? This is by Dr.
So, yeah. I think we prefer the term of ataxic or hypotonic CP better than atonic CP. And we can sometimes have a mix between spasticity, dystonia, and any part from the anatomy can be affected. So yes, so the spasticity. So the main group are the spastic, quadriplegic, hemiplegic, diplegic. The diplegic probably more common in premature baby, but any part from the anatomy can be affected. Yeah.
Thank you, sir. Let's move on to the next part of the session. And we have interesting case presentations by Dr. Pakize, Dr. Javeria, Dr. Goparaju and Dr. Ashwin. There will be 5 minutes for the presentation and 5 minutes for the discussion. So I would like to request Dr. Pakize to start her presentation.
Thank you. Hi, good evening. I am Pakize Karaoğlu. I'm a pediatric neurologist at Dr. Behçet Children's Hospital in Izmir, Turkey. I will present a case about cerebral palsy mimics. October 6th is the World Cerebral Palsy Day, and I would like to thank the organizing committee for the opportunity to make this presentation. Our case is an 8-year-old mate presented with toe walking and frequent falls while walking. His complaint started when he was 4 years old and gradually worsened with time. He was born prematurely at 28 gestational weeks and had a history of newborn ICU stay for 24 days. He started walking independently at 18 months and his cognitive development was normal. There was no consanguinity between parents and there was no family history of neurological disease. On neurological examination, his weight, height, and head circumference were in normal ranges, normal limits, and he had lower extremity spasticity. He was walking independently on tiptoes, and he had brisk patellar reflexes. Her basic laboratory tests did not reveal any abnormality, and serum creatine kinase was normal. A metabolic workup in order to differentiate the mimics of cerebral palsy were normal, and the brain MRI, as you can see here, was also normal. And in our case, the gait disturbances, toe walking, frequent falls with a history of preterm birth and newborn ICU stay, and the spastic diplegia on examination suggested cerebral palsy, which is a condition affecting muscle tone, posture, and movement due to the abnormalities of the developing brain from a variety of non-progressive causes. However, the gradual progression of the symptoms, despite the physical therapy program and a normal brain MRI, led us to think that the patient might have an alternative diagnosis. Because we expect the brain MRI to be abnormal in 90% of children with cerebral palsy, and the diagnostic power of the MRI depends on the cerebral palsy phenotype and the timing of the birth. But we expect to see on MRI, we can see PVL, cortical malformations, signs of stroke, and lesions of the basal ganglia. And when we suspect cerebral palsy and perform neuroimaging, a brain MRI, and when our MRI is non-diagnostic, then we should perform metabolic testing for inborn errors of metabolism and perform genetic tests for the diagnosis. As in our case, and particularly for all the cases with prominent spasticity, hereditary spastic paraplegias and metabolic disorders should come to the mind as differential diagnosis of cerebral palsy. The metabolic investigations of our case were normal, and genetic testing for hereditary spastic paraplegia revealed a previously reported heterozygous pathogenic variant in ATL1 gene. ATL1 gene is associated with spastic paraplegia 3A and hereditary sensory neuropathy type 1D. Our patient's clinical findings were consistent with spastic paraplegia 3A, but hereditary sensory neuropathy type 1D is associated with hyperreflexia and spasticity very rarely. So we performed an electroneuromyography, and that was normal. HSPs are different genetic conditions characterized with progressive spasticity and weakness. And in spastic paraplegia 3, we expect to see early onset motor signs like delayed motor development, lower limb spasticity, weakness, atrophy, spastic gait, mild involvement of upper limbs, hyperreflexia. Cognitive impairment and brain MRI abnormalities are very rare, and we can also see sphincter disturbances and scoliosis. HSPs and CP can both present with spastic diplegia in infancy. A significant proportion, 70% of HSP children presenting with spasticity can be misdiagnosed as cerebral palsy, and it's important to differentiate between these two conditions. So we should perform a careful clinical assessment. We should look for unexpected phenotypes and symptom progression, and we should take a detailed family history. So why is it important to get the correct diagnosis? Because we can provide better counseling to the patients and their families about the cause of the disease, recurrence risk, and the prognosis. We can direct our patient to the patient support groups, and in some conditions, we can provide disease-modifying therapy, which can improve outcome. Our patient continues physical therapy program, and orthopedicians follow him for scoliosis and other orthopedic disorders, and the genetic study of the family is going on. This is our pediatric neurology team. Thank you so much.
Thank you, Dr. Pakizan. Dr. Aiken, your expert comments, please.
Thank you very much, Pakize. This
Thank
is
you, Dr.
such a
Aycan.
such a good case, and I want to emphasize that sometimes vitamin B6 mimics cerebral palsy, especially when they have seizures. And another diagnostic patient is congenital muscular dystrophies. Sometimes basic tests are important. For example, cerebral creatine kinase. Thank you very much.
Thank you so much.
Can I say something?
Yes, sir, please go ahead.
Yeah, thank you very much. Pakize, thank you very much for your excellent presentation. Yeah,
Thank you.
congratulations for the cases. I have a question. What is your diagnostic test utility? You used neuromuscular panel, or you used whole exome sequencing based on the clinical presentation? Or is it a routine genetic testing?
It was a multi-gene next generation sequencing panel for HSPs,
It's great.
hereditary paraplegia.
Yeah, this is
Yes.
congratulations for you presumed the diagnosis, and then you ordered this panel. Panel gives you the diagnosis. Congratulations.
Thank you. Actually, it was our Dr. Aycan's case. Thank you for the case, Dr. Aycan.
Thank you very much, both of you.
Thank you.
Thank you. We are now moving ahead with the second.
Shruti, you can ask comments from other experts.
Yeah, it's open for discussion. Dr. Biju Hamid.
Nice presentation and an excellent case. Now, that's a good point, Hassan, because yes, if you suspect something and then if you have a fair feeling that we are going in this direction, yes, targeted gene panels would help. But as Dr. Brahim was telling earlier, normally you go for the standard metabolic test initially, and then you go for targeted testing. Sometimes you do look for Fragile X, sometimes you look for RET mutations, then sometimes you look for all the HSP gene panels. But then by the time, if we don't get anything, then by the time you come round to whole exome or whole genome sequencing, you would have already spent a lot of resources and time, and sometimes that it prolongs the diagnostic odyssey. And there is still a role for even bypassing targeted gene testing and bypassing metabolic testing, and then going straight to WEX and whole exome and whole genome sequencing. even in resource limited settings, if you look at all the cost effectiveness and the time, sometimes there would still be a rationale for pursuing whole exome sequencing in the first instance. I don't know, Dr. Brahim, your thoughts on it?
Dr. Brahim, if you're there. Dr. Farida, if you could.
Yeah, so I'll carry this forward. As Dr. Beju said, why not take it as the first option? In my part of the world, rather in our part of the world, the thing is that we have to pay most of the genetic or the metabolic testing from our pockets. So it's a big issue for the parents. And if we have nothing much to offer, treatment-wise, then people are very reluctant to go forward for this. So instead of taking it one after the other, as we already discussed, a good history and then a good exam and everything, we can take it forward from there and we can straight away go for genetic testing. We are opting for these things here in Pakistan now, because recently, for the past 5 years or so, we have these facilities available. We don't do it ourselves. We send it abroad, but at least now we have sort of like carriers who can carry it to other countries and get our investigations done. So I would be all for it. If I'm suspecting something, so I'll just go ahead and get that particular thing done, because parents are more in, they are more in sync with that particular thing, rather than going stepwise and taking a lot of time and, getting disheartened with whatever is happening.
Thank you, Dr. Farida. I think we'll move ahead with the next presentation. Our next presenter is from Children's Hospital and University of Child Health Sciences, Pakistan, Dr. Javeria Alvi. Over to you, Dr. Javeria.
Am I audible?
Yes, you are.
Okay. Let me share my screen. Is the screen visible?
Yes.
Okay. Thank you very much for giving me this chance to present here. Good evening, everybody. I'm Dr. Javeria from the University of Child Health Sciences, the Children's Hospital, Lahore, Pakistan, and I'm going to present a case of seizures with the global developmental delay mimicking cerebral palsy. So this is a case of a 9-month-old boy who presented to us at 4 months of age, but I would like to start with his perinatal course. So this boy was born to non-related parents, born at term to healthy mother with APGAR score of 6 and 8 at 1 and 5 minutes respectively. The antenatal scan at 36 weeks showed ventriculomegaly. He had neonatal admission due to clonic seizures that started at 5th day of life. And there was also associated reluctance to feed and feeding difficulties, because of which he was admitted in NICU. His initial exam that we retrieved from the record was the head size was 34 centimeter and he was hypertonic. He had poor neonatal reflexes. The spine examination was normal and the cutaneous examination was normal. The neonatology team did the infectious workup, which came out to be normal, including the lumbar puncture. The baseline metabolic screen was negative. There was no acidosis. The cranial scan done showed mildly dilated ventricular system, but there was no pressure signs and neither any element of hemorrhage. The seizures were fairly controlled with phenobarbital and levetiracetam, and he was discharged from the neonatal unit with the plan of extending the workup in terms of metabolic profile, because the APGAR at 5 minutes were fair enough, and follow-up MRI brain. So the workup that was done in the first 2 months showed a normal lactate and ammonia levels. Amino acids and urinary gas chromatography was inconclusive. TOS screen was negative and the bone profiles were normal. And as per the plan, the MRI was also performed. Now, if we look at this MRI of this baby, we can appreciate that there are areas of cortical atrophy frontoparietal as well as some encephalomalacic areas in the bilateral periventricular and frontal areas, and there is ventriculomegaly. If we see the T1 images, so there are bilateral T1 weighted hyperintensities in the basal ganglia and part of subthalami as well, along with the dilated system. And on the sagittal view, the corpus callosum is not very well visualized. Rather, it is agenetic, and also there is some retrocerebellar cyst. So if we see in the context of clinical symptoms, and then correlated with radiology, even HIE patients can have diffuse cortical involvement and cystic lesions with basal ganglia and thalami and watershed area involvement, especially when it comes to asphyxia in children who are born at term. So initially he was labeled as cerebral palsy, but when we saw this child and the further course at 4 months and 6 months. So at 4 months, he had developed severe arching episodes, epistotonic posturing, for which we had to start him on baclofen. And ultimately, he was so spastic that there was all 4 limbs were spastic with severe muscle wasting. And he had achieved no milestones in terms of no neck holding or any eye contact. And there was progressive microcephaly with overriding of sutures, axial hypotonia, but appendicular hypertonia. So we again correlated the clinical and the radiological context, and considering the T1 hyperintensities in the basal ganglion thalami, we thought of some intoxications as well, keeping in view that there was agenesis of corpus callosum, which is not usually seen in HI patients. So we went ahead and investigated him further. The uric acid levels came out to be very low, and the whole exome sequencing performed showed mutation in the MOX2 gene, which was consistent with molybdenum cofactor deficiency type B, and confirming the diagnosis. So now at 9 months of age, the child is globally delayed with no gaze fixation, neck holding. He has feeding difficulties. He has microcephaly with OFC of 43. His seizures are fairly controlled, but the main issue is spasticity, as was just shown in the previous presentation, that molybdenum cofactor deficiency is more associated with spasticity. We are giving him supportive treatment and therapy, and we have started pyridoxine also, which sometimes help in MOX2 deficiency. But we have this genetic diagnosis of molybdenum cofactor deficiency, which was initially labeled as an HIE sequelae. Coming back to the MRI, how can we differentiate this radiologically? Radiologically, clues are also there that differentiated from HIE in terms of presence of, in terms of presence of this giant megacisterna magna on Daddy Walker variant, and then hypoplastic corpus callosum, and then the evidence of prenatal brain degeneration, which was there if we review this case retrospectively, that there was a ventriculomegaly on an antenatal scan also. Which so these can give us clue which can differentiate it from the HIE sequelae becoming a cerebral palsy. I would quickly just want to give a brief presentation of another case which was actually labeled as cerebral palsy for 2 years when we then started seeing this child. So this girl was actually having a seizure since 3 months of age, was delayed as per 6 months of age, and having microcephaly. She was born to a hypertensive mother, and that's what the risk factor was labeled as a cause of cerebral palsy. There was PD on echo, and there was calcification on CT. Here you can see that there are some thalamic calcification here. So torch is very much common here. So we even torch was done, which was negative. But she had a changing seizure semiology, which evolved into infantile spasms and modified hips arrhythmia on EEG. And then steroid was started, and the protocol of epileptic encephalopathy was given. Since she was not improving, and there was 4-limb dystonia, here you can see in the video. So an MRI was planned and done, and it shows symmetrical bilateral white matter changes and even cystic changes in the bilateral temporal lobes, which give us a mimic of even Van Den App, but the course was not like Van Den App disease. So she continued to have progressive microcephaly, and ultimately she also developed glaucoma. And I will show you the genetic testing, which is associated with this glaucoma formation later on. So you can see that she is microcephalic, she is spastic, she has no eye contact, and she is totally bedbound. So the genetic testing was, so the differentials that were considered in this case were overlapping. Maybe perinatal issues because of she was born to a hypertensive mother, torch infection considering PDA and calcification on CT, molybdenum cofactor deficiency because of the encephalomyelitic changes, and Aicardi-Guterres because of microcephaly and thalamic calcifications. So the whole exome sequencing actually told us the diagnosis precisely that she had an RNase H2C mutation, which was consistent with Aicardi-Guterres syndrome. And again, I would say that these children, these disorders, they do have an overlapping features with HI and sometimes post meningitic sequelae and genetic disorders. So the conclusion is that whenever we have a progressive course, whenever we have red flags, just like Professor said, and we have a progressive course with changing seizure semiology, spasticity, or any neuroimaging that would lead us to change the diagnosis, we should always go for genetic testing, and which will help us maybe in the treatment and in the prognosis and genetic counseling. Thank you.
Thank you, Dr. Javeria. I would like to invite the experts to give their comments on these cases. Beginning with Dr. Farida Jan.
So very well presented, very well thought cases. Thank you, Javeria, for giving us some food for thought. So
Thank you.
just one point, when we say, rather when we see a case like this in which we have these calcifications, and when we think about TORCH, so the next thing that we think about right next to it, and especially with a girl, would be Aicardi-Goutieres, because it is also known as pseudo-TORCH. So this should have been like hand in hand right from the beginning. And as for the first case, that was very interesting and very well worked up. And the after view of how you reached the diagnosis, I really loved that. So thank you very much.
Thank you.
Thank you, Dr. Farida. Dr. Biju Hamid, if you could say
Thank
two words.
Thank you. Thanks, Javeria. Like excellent cases. And in fact, like two typical examples where you can go wrong. Excellent mimickers of CP, isn't it? Mocod and Aicardi-Goutieres. And so very timely presentation and very well presented as well. So obviously, like let's take the second child. You know, and it was 2 years by the time the diagnosis was made. And in our CP clinic, we see loads of Aicardi-Goutieres, you know, all like 1, 2, 3, 4, 5, and like thing. Would you go back and change that original diagnosis of CP, or would you keep the diagnosis of CP and give an additional label of Aicardi-Goutieres?
If we say that the CP is a disorder of movement and posture, then yes, this child was having it. If we ever say that it is because the diagnosis is Aicardi-Goutieres, which is actually causing that problem, it comes under the umbrella, you can say.
So how would you counsel the family in this instance? Would you say that no, we got it wrong? Your child hasn't got CP. We have now found the right diagnosis, or what's like just out of interest? Like, what's your approach towards families? And after that, I could tell you what my approach is in our clinic.
Yeah, that's a very valid question, because these are the issues that we are facing, because this child actually came to us at 2 years of age because he was being treated as cerebral palsy at some periphery, because they belong to a very far-flung area. So when we saw the CT brain, and then we ordered the MRI afterwards. So definitely we do counsel them about the exact genetic diagnosis. Aicardi-Goutieres also needs supportive management if we and we have to screen them for all the complications that can come, like strokes, glaucoma, chilblains, and other things. We totally don't negate them because they were having a diagnosis for the first 2 years at some other center, but we do tell them that these children also have these problems, so there is an overlap. This is how we go about it, and I would love to know how you go about it when they're presenting to you at the first time and getting a real diagnosis.
No, it is a very tricky situation,
Yes.
and now the CP consortium has advised that we use the term, we use it as an umbrella term.
Yeah.
Because and I was, when Dr. Shafali invited me, you know, the term the AOCNA had given us is like uniquely CP, because the CP definition has been like made too over simplistic, and we know that, you know, for any child living with CP, you know, it's unique. It's a very complex, multifaceted condition.
Yes.
It's very unique to that individual. Involves all the physical, social, emotional, psychological runs, everything. And so this particular child, so it's been 2 years with living with CP. The CP is the identity. So it has got severe spasticity, the delay in development, and the movement disorder. And then we find that like it had a genetic basis, which explains the difficulties to the family. So the family suddenly has a closure. They know it was nothing that the mother did wrong during pregnancy or something that went wrong with the hospital, the way the hospital looked after the child. They now have a closure. So the way we approach it is like, yes, the child still has CP with all the comorbidities associated with it, but that CP is due to a mutation in a particular gene. And that's how we present it. So because the diagnosis is the identity of the child, isn't it? So
Yes, that is true.
the genetic diagnosis does not really displace a CP diagnosis, because it will impact upon the identity. Because these families will go on social media saying like, oh, my little 2-year-old with CP, particularly in the West, because that's the identity. The genetic diagnosis only brings clarity to the problem.
Diagnosis.
Because the family would have already constructed a very social narrative around this child's life. And we don't want to disrupt that, because that probably would have provided the family with the essential support from the society, and when it comes to education as well. So, and why upset that? Why saying like, oh, this is not CP, this was a mimic of CP, we now found a diagnosis. So that's our approach. We still use CP so that they can access all the social care that they would get because of the label of CP, but explain to the family that this is why your child's got CP.
Yeah.
Thank you, Dr. Vijay.
Thank you.
Well, point well made. Dr. Aidan, your comments, please. Dr. Aidan? Okay,
Go to the next case.
yeah, our next presenter is from AIMS, New Delhi, Dr. Goparaju. Could you please share your screen, Dr. Goparaju?
Dr. Manidipti, please
Yes,
share
ma'am.
your screen.
Good evening,
Yeah.
ma'am.
Good evening.
Is my screen visible, ma'am?
Asmita, please help.
Hello. No, your screen is not visible. You have to hit the share screen button first.
Is my screen visible, ma'am?
Yes.
Make it full screen. Yeah.
Is my
Yes,
audio
Dr.
okay? Fine, ma'am. Hello.
Yes, Dr. Manidipti, please.
Thank AOC. Yes. Good evening, all. At the outset, I would like to thank AOCN for giving me this opportunity. Today, I am going to discuss an interesting case: the metal of static
Manidipti, you are
dystonias.
not audible.
So here are the case details. It's a 2-year-old girl presented with total gestures of all 4 limbs. 2-year-old girl presented with a delayed attainment of milestones associated with abnormal involuntary twisting postures of all limbs noted from early infancy. So the birth history was normal. First born to the 3rd-degree consanguineous couple, rest uneventful antenatal period, full-term gestation, normal delivery, birth weight of 2.3 kgs, cried immediately and was discharged. There was no evidence of neonatal encephalopathy or neonatal seizures. So coming to the developmental history, there is a significant developmental delay in attainment of various motor domains, language domain, and socio-adaptive domains. So current age is 24 months, and the child have attained rollover unidextrous grasp. Current developmental age is 7 months in all the domains. So there is no significant antenatal or perinatal insult. Postnatally, there is no history of any significant illness requiring prolonged hospitalization. On examination, there is no facial dysmorphism, no neurocutaneous markers, the spine was normal. We can see the abnormal twisting postures of all 4 limbs. So anthropometry is within normal parameters. On CNS examination, higher mental functions were normal. Alert, the child is alert, awake, interacting with parents. Cranial nerve examination is normal. Motor examination, bulk is normal, tone is variable. The child had anti-gravity movements present and the DTRs were normal. So here in this video, we can see the abnormal movements, sustained involuntary twisting movements leading to the abnormal posture can be seen in all 4 limbs and neck. We can see the hyperextension of neck and the striatal toe consistent with generalized dystonia. Systemic examination was normal. So to summarize, 2 years female, first born to 3rd degree consanguineous couple, global developmental delay.
Later, the child visited our casualty with
Generalized dystonia, normal vision,
child
hearing
in the
and
open
normal
state is
extraocular movements, no dysmorphism, no neurocutaneous markers, no organomegaly. So clinical diagnosis is a non-progressive generalized dystonia. So the first possibility will be a dystonic cerebral palsy. However, there is no clear prenatal, perinatal or postnatal inset, and the jaundice was reported on day 3 was not significant enough to cause bind. So other causes can be primary generalized dystonias, but they usually have dystonia at an early childhood onset. So then we went ahead with a neurological imaging. MRI brain was done. So we can see the T1 weighted images. Bilateral hyperintensities are seen in a globus pallidus with a corresponding T2 weight, and the FLAIR images, symmetrical hypointensities are seen. So the susceptibility weighted images here shows a blooming in the bilateral globus pallidus consistent with mineral deposition. So hence the other possibilities that we considered were, so NBIA spectrum, that is INAD, which have an early onset dystonia. So however, the INAD have other presentations like cerebellar signs and the pyramidal signs with MRI brain suggestive of cerebellar atrophy. And the other features of NBIA are a little bit very early for this presentation. So other possibility is a hypermagnesemia. It's since the child have an infantile onset generalized dystonia with a history of consanguinity present with the MRI brain suggestive of mineral depositions in the GP, we went ahead with the genetic testing. Now the genetic testing shows a likely pathogenic variant, homozygous variant in a SLC39A14, which is a manganese transporter gene. Now the final diagnosis is hypermanganesemia with a dystonia 2, type 2, with a homozygous mutation in SLC39A14. So the blood investigation shows increase in the serum manganese levels, which were very much elevated. Rest trace elements were within normal limit. So the hypermanganesemia with dystonia, there are actually few case series and case reports that have been published. So this is one of the study that is done in an Indian population. So based upon the available literature, we have 2 types of hypermanganesemia dystonia. One is type 1 and one is type 2. Type 1 is with the SLC30A10 variant and type 2 is SLC39A14 variant. So the type 1 have both childhood onset forms and adult onset forms, which usually presents with a dystonia Parkinsonism features. So one important distinguishing feature between the type 1 and type 2 is type 1 have a liver cirrhosis and polycythemia and skin discoloration. So type 2, there will be a relative cognitive sparing and there will be no liver cirrhosis. However, the dystonia is severe generalized dystonia is seen. So the treatment, there is actually a paucity of data regarding the treatment consensus guidelines for the management of hypermanganesemia. However, based on the available literature, so the treatment is a chelator therapy. Mainly we use disodium calcium editate twice daily for 5 days, 20 mg per kg per dose. So while we are giving a chelation therapy, we should watch for hypocalcemia, nephrotoxicity, trace element, and vitamin deficiency, thrombocytopenia, and leukopenia. So the treatment should be discontinued if any of the following occurs, like leukopenia, thrombocytopenia, and the urine proteinuria of more than 2+. So, so this is a protocol that we have designed that we follow in our institute. So we give calcium EDTA 20 mg per kg per dose in 250 ml of NS given over 1 hour under cardiac monitoring twice daily for 5 days with a proper vitals monitoring. So after that, we can do a serum manganese levels once every 2 monthly. So currently the child have received 2 cycles of calcium EDTA chelation therapy, and the improvement can be seen in a dystonia rating scale. So the take-home message would be non-progressive dystonia can have genetic etiology. Hypermanganesemia with dystonia may mimic CP in a young infant. The entity is potentially treatable, so early suspicion is required. Bilateral GPI T2 hypointensity may be clinching the diagnosis in a suggestive scenario. Thank you.
Thank you, Dr. Manidipti, for that interesting case. I would like to invite the moderator for this case, Dr. Prashant Johari, for his expert comments.
Thank you, Shruti. So I don't have much to add here. It's just that sometimes we don't have to be very dogmatic about the progression, especially in early infancy. So here we didn't find much of a progression in this child. However, because the baby was quite alert and there was some discrepancy, we started from the very beginning, we were thinking of some genetic etiology. And when we did an MRI, so we got a definite mineral deposition, and therefore we were able to get to the diagnosis. So in our clinical practice, I would just say that whenever we don't have a clear-cut perinatal or postnatal history, the radiology or the phenotype, there's a mismatch in any of the three, then you should start thinking of a diagnosis which is not cerebral palsy. Thank you.
Thank you, Dr. Prashant. I request the experts to give their valuable comments.
Excellent case and nicely presented. And I think if you look at all the cases that have been presented today, they're all typical mimickers of CP. And if you look at the history and examination, they all had excellent clues from the very beginning itself. And the important points that Prashant said, like, it's very important to think about these conditions and not go in one direction. So excellent cases, and they're all like worth keeping in mind when you see any children with problems with movement and posture.
Thank you, sir.
So it was indeed very interesting, Manidipti. And yes, we also have these cases with hypermanganesemia here in Pakistan, and the type 1 have been isolated, genetically proven. I have a number of patients, and it is indeed a very close mimic of CP. Again, it will only be if you have a higher index of suspicion only, then you will be able to catch it. And of course, in this case, the clue was in the MRI. So well done. Thank you. It was a very well presented case.
Thank you, ma'am. Let's move on to our next case. It is by Dr. Ashwin Sardesai from KLE Dr. Prabhakar Kore Hospital, Belgaum, Karnataka. And the moderator for this case would be Dr. Mahesh Kamte. I would request Dr. Ashwin to share his screen and start the presentation.
Is it visible, my presentation?
You can share the screen as well. It's not seen.
Is it visible now?
It's seen. Yeah, it's seen. Make it full screen.
Is it full screen now?
Yeah.
Yes, Dr. Ashwin.
Okay. Thank you for the opportunity to present today at this AOCN meeting. I'm a DM Pediatric Neurology resident under Dr. Mahesh Kamte sir at Jawaharlal Nehru Medical College, Belgavi in Karnataka. Our topic for today is genetic cerebral palsy or cerebral palsy mimics. Can we draw a line or is it a gray area? So we present a case which is a 1 year, 7-month-old male child born of a more than 3rd-degree consanguineous parentage with an uneventful antenatal period, born by LSCS because of a previous LSCS with a 2.5 kg birth weight, cried at birth, no NICU admission, had developmental delay noticed at 6 months of age, with head holding at 6 months, rolling over at 1.5 years, and is now able to stand, but with the support of the wall behind, and is unable to sit on his own. He falls within a few seconds. So there is no pincer grasp. He's only able to grasp objects placed in the hand. He's only cooing, not babbling yet. He recognizes the parents and has stranger anxiety at 1.5 years. There is history of some irritable behavior, no history of seizures or reduced vision, hearing. On examination, microcephaly is noted, and there is some mild dysmorphism in the form of a broad philtrum. So the oromotor dysfunction is present. There is drooling of saliva, no strabismus, spasticity and dystonia noted in all 4 limbs on CNS examination with truncal dystonia as well. And the deep tendon reflexes are brisk. The other system examination was normal. So this child's diagnosis was mixed spastic and dystonic cerebral palsy with a GMFCS of 4, Minimax 4, EDAX 3, CFCS 4, VFCS 1 with global developmental delay, with microcephaly, with dysmorphism, with oromotor dysfunction, with a etiology not found, so it was cryptogenic. So at this stage, an MRI was performed, and the MRI also was not contributory. This MRI was done at 7 months of age, when the developmental delay was first noticed. And as we see that the T2 and FLAIR images do not show any abnormalities, the myelination seems appropriate for age. The posterior limb of internal capsule and the cerebellar white matter are myelinated. Other than a mild thinning of a corpus callosum, there was no other abnormality noted. So under MRI-CS category, this falls under the miscellaneous, which is category D. So at this stage, the child was suspected to have probably a genetic etiology. And so we ordered a whole exome sequencing. And the diagnosis which came was an RNA-SC H2B gene, which is for Aicardi-Gouttiere syndrome 2. Now, this was not something that could have been expected based on the clinical history and the examination. And as we know that it usually presents with infantile subacute encephalopathy, sterile pyrexias, which later evolve over months with loss of previously attained skills and acquired microcephaly and tone changes. But in our case, there was nothing like that. There were no recurrent febrile illnesses, no skin findings, no calcification on the MRI, SWI images, and no progressive course which was noted. So we also want to show that we have had 2 more cases which have been diagnosed as AGS with a non-progressive course. One of which was a TREX1 gene, the other was an RNase H2A gene. And the TREX1 gene case was a dystonic quadriparesis, a 22-month-old child with second-degree consanguinity, global developmental delay, microcephaly, uneventful perinatal history, and has not achieved head control with no social smile. And the MRI showed abnormal myelination and cysts in the temporal region. Whereas the child with RNase H2A gene showed was a 5.5-year-old child with third-degree consanguinity and microcephaly and developmental delay with a good cognition, with a MRI showing white matter hyperintensities more present posteriorly than anteriorly, and a significant history of a maternal uncle with diplegia diagnosed at 12 years of age, with thin corpus callosum and periventricular white matter changes. The common thing of all the 3 cases were that they had a non-progressive course with a developmental delay which was noticed in the early infantile period, and or the motor abnormalities were noticed very early, and they were gradually gaining milestones, no regression, no intermittent worsening. So these 3 cases fit into the purview of the definition of cerebral palsy, and we would like to say that these cases are probably a genetic cerebral palsy rather than cerebral palsy mimics. We went into the literature review and we found that there was previously reported 3 cases where genetic testing contributed to diagnosis in cerebral palsy, and they found a case of SAMHD1 gene and 2 cases with RNase H2B gene. And they suggested, the Diane Bazin et al., they said that rather than AGS being that AGS may be a common cause of CP and may be undiagnosed without genetic testing, and that it must be considered in cases with spastic CP even in the absence of characteristic brain abnormalities. So whether it's a CP or CP mimic, we know that AGS is a rare hereditary inflammatory disorder which usually presents in early infancy and is a type 1 interferon-mediated interferonopathy. And there are multiple genes which have been implicated with AGS. And here it is known that it is because of the self-nucleic acids, which are no longer recognized as such, leading to an inappropriate immune response with an overactive type 1 interferon signaling, even in the absence of viral infections. The suggestive features usually are CSF lymphocytosis and neuroradiological findings of calcification in the basal ganglia and leukoencephalopathy, progressive microcephaly, spasticity, epilepsy, and developmental delay. And the systemic manifestations classically, as we remember, like hepatosplenomegaly, skin rashes, chilblain, glaucoma, SRE-like manifestations. These are all the classical presentations. But of late, there have been several studies which show that there is a broader spectrum of disease presentation with progressive, with the wherein that static and slowly progressive forms presenting as CP are known, and genetic studies on cerebral palsy have had RNase H2B and TREX1 genes reported as causes of CP. So so we also have had like to show some 4 more cases which are of congenital disorders of glycosylation, which have a CP-like presentation, which have presented in early infancy, which have had a non-progressive course, and they were of ALG11 gene, PMM2 gene, ALG1, and COG5, wherein hypochronic quadriparesis, ataxic, dystonic, mixed dyskinetic, and spastic quadriparesis, wherein the MRI, if we see, has fallen in the categories of D, E, or A, and and have had not had a progressive course. So what we would like to think that is that in the categories A, D, or E, wherein the MRI shows mild developments or miscellaneous features like hypomyelination or corpus callosal thinning or just some cerebellar atrophy, or if the MRI is normal, then we should strongly suspect a genetic cause of CP. And even if a gene is identified, then whether these genes are to be considered as causes of cerebral palsy and call them as genetic CP and not as cerebral palsy mimics who are masqueraders in whom we would expect some normal development prior to the delay noticed later, or some regression or intermittent worsening and features like that, which hint towards a mimic and not as a cryptogenic CP. So we would like the opinion from the experts as to whether like when do we conclude that the child is CP or is a CP mimic? Like how long do we wait? Because the worsening might not have occurred yet. The MRI features may not have happened yet. And how do we counsel such a patient once we have a genetic diagnosis? And we continue to keep that cerebral palsy as an umbrella term and use it like epilepsy, wherein we say that the child has epilepsy due to a certain genetic cause, or we say that cerebral palsy due to a genetic cause. So over to the panel. Thank you.
Thank you, Dr. Ashwin, for that interesting thought and interesting presentation. Dr. Mahesh Kamte, sir, your comments, please.
Dr. Zaberi had presented a case of AGS, and Ashwin has presented 3 cases of AGS. The main difference between these two is in our series of 3 cases, there is no progression. We enrolled the student at age of 1 year, and we continue to follow them for the next 1 to 2 years to look for any progression. There is no progression in these symptoms. So these children did qualify for a level of cerebral palsy. Because we have followed up for almost 2 to 3 years and no progression in their symptoms. We don't know if they'll progress in future. So the genes like AGS, HSP genes like spastic paraplegia genes, they can present as cerebral palsy. When we review the literature for spastic paraplegia genes, there is a gene by name SPAST1 gene. And in this SPAST1 gene, if you have a truncating mutation, they present as typical hereditary spastic paraplegia. That is, they are normal for the first couple of years, and then they develop spasticity and they have a progressive course. But if they have a missense mutation in the same gene, they can present as cerebral palsy. So this is just another example of how one gene can present in different forms. Like a gene in SPAST1 can present as both a progressive disease like HSP and at the same time a static disease like cerebral palsy. So similarly, we need more studies, more literature on these genes on different presentation, so we have a clear-cut picture, okay, whether it's a CP or a CP mimic. There is one more example I'd like to give is like a KSNQ2. Like if you have a KSNQ2 gene, if you have a nonsense mutation, they present as self-limiting neonatal epilepsis. But if you have a missense mutation with there is gain of function, they can present as a DE. The same gene, the type of mutation will decide whether it's a self-limiting or a DE. Similarly, same gene like AGS gene or HSP gene can present as a progressive spastic paraplegia or a cerebral palsy also. So more studies, more case reports, and more functional studies can help us to make this differentiation. So I think we are again blurring the line between CP and CP mix, but it's a very interesting growing field. And in the next coming years, we'll have more clarity on this topic. There's one comment by Dr. Patra. Should we include neurometabolic disorders as a type of CP? Okay. So again, when it comes to IEMs and CP, okay, you can classify them into 3 groups. you may have one type of IEM wherein treatment can completely reverse the disease. For example, you have a child with biotin deficiency or child with pyridoxine dependency. By giving treatment, if you can completely reverse the disease, then they can be treated as treatable IEM. In one more type, you have got disease like GA, Glutamate residue type 1. Child is normal till 6 months, has a crisis, and then you diagnose it as GA1, and you treat the child properly with proper dietary management and proper nutritional support, and the child will not have any further episodes. So you can still give a level of cerebral palsy. CP due to GA1 has been managed properly. But if you don't manage the GA1 properly, it is a neurometabolic disorder, not a CP, it's a CP mimic. But if you manage the disease properly, it will be cerebral palsy. But if you have a IEM which is progressive, not available to treatment, then it becomes a CP mimic. So each disease can behave in a different way. So ultimate message is follow these children properly. If the follow-up shows that there is no regression or loss of attained milestones, we can give level of cerebral palsy. Don't go by the name of the gene, because this gene can present a CP also. Because we have done this mistake in the initial part of my career. When you had as HSP gene, we always told the parents that it's a progressive disease, child can worsen. But now I have follow-up of almost 10 years now. They have done quite well. They're almost static like a cerebral palsy. So now the way we counsel these parents has really changed, because we know that these children can present as CP, not as a progressive disease. So more literature, more information on these topics will give a clear picture for this. I'd like to get expert comments from both Biju, Farida, and Aisan, please. Your experience.
Thanks, thanks, Mahesh. And thanks, excellent presentation, Ashwin. Very nice summary. There are lots of take-home points from that talk. I think, particularly, in the previous case, like we talked about ICARDI and we talked about calcifications, and that's very, very important to know that, because we are increasingly, we have many number of ICARDI good years now, like I think it's up to 5 or 6 now, isn't it? So we don't need calcifications, we don't need chilblains, we don't even need abnormal MRI. It can still be ICARDI. So you still have to have that high index of suspicion. And in some of the RNA-CH2 children that we look after are completely normal, as in like MRI is normal. There's nothing in the history, no chilblains, no calcification, nothing. Maybe some isolated brain atrophy over the years, but nothing really significant, unless like you do the genetics and then you find. And the important thing is there are now treatments available, isn't it? As you know, the Janus kinase inhibitors are available. We use Cheryl Hemingway and the team uses baricitinib for ICARDI. Even if they don't have any calcifications, or even if they don't have chilblains, so you still use try baricitinib. The MRI classification you mentioned, that's a good point. If you have cortical malformations, then but the MRI classification is basically to try and to find out the timing of the injury, isn't it? So if you see maldevelopments, then we know that it is probably early first trimester, or maybe like early second trimester. And then, like as you see white matter injury, then you go into the second trimester or early third trimester. And then if you see gray matter injury, then you are quite late, towards the late third trimester. But obviously, if it is category, the miscellaneous category, D and E, then you have to suspect that there could be something else. Also, if you see cortical malformations, you have to suspect. So that's a good point, like category A, D, E, like, you suspect genetic. But most important point is what Dr. Mahesh was saying, that it is still cerebral palsy. That's what we discussed earlier as well, because even with HSPs, sometimes in some HSPs, the progression is ever so slow that you go into your 30s and 40s and 50s to see the progression. And there's no point in like changing diagnosis. It is still CP. So those are all very important take-home messages from both your messages now, both Dr. Mahesh and Ashwin. Thank you. Excellent.
Thank you, sir.
Thank you, sir.
So, Ashwin, thank you very much. The best part of your talk was when you came up with the terms genetic CP. So this was bugging me since a very long time, that CP does not embrace everything and the way we use it. But when we say genetic CP, and then probably in the long run, we'll come up with a classification of having acquired CP, a number of things will fit into those categories. So the question that you asked, till when should we wait and when should we progress to declare them CP or the other way? So that's, I would say that would be very individualistic. You cannot categorize per se. We'll have to like literally take up every case and then see to what extent we go. Like the one which Javeria showed that was already like 2 years old when they reached them, or the one which Pakiza showed earlier, that till 4 years there was no sign and then something just turned up. So in pediatrics, I personally feel we cannot like draw a specific line somewhere that we can do it till then, and after that, maybe we can give it a label otherwise. So I would say that would be totally on your suspicion. How soon can you have that suspicion? How soon can you pick up that aroma that something is more to it? It's just not plain acquired CP, I would say. I would love to use these terms if nobody minds them. And it's not a genetic CP, that is. So thank you very much. It was really worth listening to your talk.
Thank you, ma'am. In view of lack of time, we'll be moving on to our last case for the session.
Yeah, I was just thinking, one second is pitching in 1 minute. We should have a debate, and we can have speakers from various continents to speak on when to label CP and when not, something like that, Dr. Bejo. Obviously, you are going to be in that debate, and even Dr. Farida. So I think we should have, because it's, I mean, in such cases, when to label it becomes ambiguous. It's not ambiguous, it becomes very debatable, and because of, trying to understand the prognosis and telling everything. I mean, it's still CP is still a clinical diagnosis, and like, it's very much debatable either way. So that I think maybe we can have a debate before the end of this year. Can go to the last case, Arvinder from Bhatinda.
And I would say that if you give me time, please. It is important that I think not every hospitals have VES or VGS. For that reason, clinical suspicion important. And I think not all of the cerebral palsy patients detected for genetic tests because it's very difficult. For example, we have not yet have VES and VGS. I don't know. Can I tell to you? Thank you very much.
Thank you, Dr. Aidan. Our last presenter would be Dr. G. Madhu from AIIMS Bhatinda. The moderator for the session would be Dr. Arvinda Vanda. Dr. G. Madhu, could you please share your screen? Dr. Madhu?
Yes, ma'am. Asmita, could you please share the screen? Ma'am, I'm not able to share my screen, so I have sent her the PPT and I've asked her to share. Good evening, everyone. Myself, Dr. Madhu, Junior Resident, Second Year, MD Pediatrics from AIIMS Bhatinda, will be presenting a case. We are presenting a case of 10-year-old male child who was a preterm born out of a non-consanguineous marriage at 35 weeks of gestation with birth weight of 1.5 kg, cried immediately after birth. There is no documented perinatal hypoxia or hypoxic or hypoglycemic insult. However, the child was admitted in NICU for 3 days in view of low birth weight. There is no history of neonatal seizures, fever, or jaundice. Currently, the child presented with difficulty in walking, difficulty in speech, noted since early infancy, and poor academic performance. In early infancy, the parents started noticing that the child walks with his knees close to each other and holds his hips close. The child has normal bowel and bladder control as well as intact sensation for pain and temperature. There's no history of diurnal variations or fluctuation of symptoms. They also complain of poor clarity of speech, and it typically appears as if the child is speaking from his stomach. There's no history of jerky or irregular speech or drooling. There's no history of regression of attained milestones, abnormal involuntary body movements, abnormal urinary odor, excessive lethargy. There's no vision or hearing abnormality. There's no history of recurrent infections, frequent falls, and there's no significant history related to other systems. And there's no significant family history in this case. The child had delayed attainment of milestones, predominantly motor milestones, and has poor scholastic performance. Has been immunized as per national immunization schedule till date. The child is conscious, oriented to time, place, and person with MMSE score of 21, with difficulty in arithmetic calculations, memory, and abstract thinking. There's restriction of speech output with poor articulation and reduced clarity of words. However, comprehension, naming, repetition, and appropriate content of speech is noted. There's exotropy of left eye on cranial nerve examination. Could you please play the video? The child walks with short steps, keeping his thighs close to each other, knees and hips flexed, dragging each foot. This is a narrow-based gait. There's no difficulty in initiation of the gait or taking turns. Sensations are intact. On detailed motor examination, muscle bulk is decreased, tone is increased, that is grade 2. Power is 4/5 in bilateral lower limbs with exaggerated deep tendon reflexes and extensor plantars. Examination of upper limb and spine was normal. The child had already got an MRI done from the outside hospital, which was normal. In view of muscle weakness and low power, we had done a CPK level, which was elevated. That was 714 units per liter, and rest of the biochemical parameters were within normal limits. Summarizing the case, a 10-year-old male born preterm out of a non-consanguineous marriage presented with global developmental delay, intellectual disability, and spastic diplegic gait. Parents complained of tightness of lower limb and difficulty in speech, no seizures, extrapyramidal symptoms, or contractures. The child has intact vision and hearing. There's no significant family history. And neurological assessment revealed spastic diplegic gait with decreased muscle bulk and power, increased tone in bilateral lower limbs with hyperreflexia and extensor plantar response. Investigations revealed elevated CPK, and neuroimaging done in the outside hospital was normal. So due to differences in the clinical phenotype and the imaging, spastic paresis with ID and normal neuroimaging is seen in our index case, and differentials kept for the spastic paraparesis were hereditary spastic paraplegia, dopa-responsive dystonia, and other neurotransmitter-related disorders, late onset biotinidase deficiency, arginase deficiency, cobalamin pathway defect, and juvenile onset Krabbe's disease. Due to the differences in the clinical phenotype and the imaging that was seen outside, we had repeated an in-house MRI brain, which revealed abnormal T2 flare hyperintensity noted in the tip of the frontal horn of lateral ventricles, which is compared to the ears of lynx, hence the name ear of lynx sign, which was suggestive of hereditary spastic paraplegia involving SPG11 and SPG15 genes. Whereas when we did the genetic testing, whole exome sequencing, it revealed mutation in the EPG5 gene, which was homozygous pathogenic variant indicating VC syndrome. It has autosomal recessive inheritance, and parents were heterozygous for the same. In patient with VC syndrome, although we have seen some overlapping features in this case, which were acceptable, but there are some contradictions like hypertonia, which is not specifically seen in VC syndrome. Hence, the diagnosis was skeptical. Then we went through the literature and found that there's a group of disorders, congenital disorders of, could you please go to the previous slide? Congenital disorders of autophagy. These are the emerging novel class of inborn error of neurometabolism, including EPG5-related VC syndrome, and SPG11 and SPG15 are also involved in this. Then we did a detailed phenotypic examination of the child, which revealed subtle facial dysmorphism with a broad nose, hypopigmented patches over the cheeks, which the mother informed that were present since early infancy. This is a table wherein we have put up the overlapping features with VC syndrome and hereditary spastic paraplegia in our index case. The child had facial dysmorphism, cognitive disability, hypopigmented patches, muscle weakness, and EPG5 mutation that was revealed on genetic analysis, which points the diagnosis towards VC syndrome. He also had hypertonia and cognitive disability, which is common for both and directed more towards hereditary spastic paraplegia. So this combination of genotype mutation of EPG5 and spastic phenotype challenges the existing diagnosis and the undermining complexities of the genetics. Since I went through few literatures and then please change the slide. I went through the literature and found that although other genes are also involved, EPG5 and SPG11, EPG5 for VC syndrome and SPG11 related to hereditary spastic paraplegia, both commonly are intersecting in the pathway of autophagy. This novel crossover led to the pathway that we could correlate for this specific case in specific index case. So take-home messages from this case were, when the MRI findings doesn't match with the clinical phenotype, it's important to get imaging with higher resolution and review the case. When genetic variant doesn't match with the clinico-radiological phenotype, it's important to go through the literature to find a common link that can explain the underlying biological pathways. Thank you.
Thank you, Dr. Madhu. Dr. Arvinder, your comments, please.
This case was a 10-year-old male child who presented with ID and spastic diplegia. Our in-house MRI was suggestive of fear of Lynch sign, which Dr. Madhu has shown. So when we see such sign, this is specific for hereditary spastic paraplegia 11 and 15. So our straightaway possibility was SPG11 or SPG15. But our genetic testing was revealed VC syndrome, which generally present which is generally a multi-system disorder which presents with cataract, immunodeficiency. These features were not there in our case, and that syndrome has specifically hypotonia. But our case has spastic diplegia. So when we reviewed the literature, we found in the pathway that SPG11 is involved in that specific pathway. So this was our novel finding, which we found in this case, that we got the hypertonia with spastic diplegia-like presentation in VC syndrome. It is never reported before, so this was important to be presented because outside MRI was reported normal, and parents were labeled, the child was labeled as CP because he was born premature. He was 1.5 kg, so pediatrician has already labeled it as a PVL type of spastic diplegic like CP. So this was our case, and what we could have initially picked up that hypopigmented patches, which we missed on the initial presentation, and these were also hypopigmented patches and peripheral neuropathy features because this child had CPK raised. Generally, HSP has purely spastic diplegia, and peripheral nervous system can be involved in HSP plus features, but these only few things like hypopigmented patches and peripheral nervous system involvement were subtle red flag for pure HSP phenotype.
Thank you, Dr. Arvinder, for that interesting case. And I would ask the experts for their comments, please.
No, excellent case. It's very enigmatic, like a nice ending to the session. Excellent case, because these children often present in the neuromuscular clinics. I know Adnan Mansoor and Heinz Youngblood, guys, they had patients. I think they were in the paper, that the autophagy review paper. The CPK might be a clue, isn't it? Because the CPKs are not raised in any of the other conditions. So the CPK raised, but interesting, like, so this child did not have any frequent infections or anything.
So there was nothing like no cataract, no immunodeficiency, no cardiac involvement. But pure spastic diplegial gait, and with the nothing, there was no other features.
Because it's a very high mortality and morbidity in these cases, isn't it? With VC syndrome, I think so. Yeah.
Literature says that all these VC syndrome groups of CDG, congenital disorders of autophagy, they present with a profound hypotonia. So these children are mostly
and they often succumb to repeated infections, and because the immunodeficiency is quite yeah. When we haven't seen anything, but this is fantastic, like that overlapping between SPG and C. So very, very interesting case. Thank you very much for presenting this. You've already published this or written this up? Or?
Sir, this has been submitted in pediatric neurology as under review.
Fantastic.
Dr. Tipu, you joined. I just saw you. Any comments, Dr. Tipu?
Yeah. Thank you, Shefali, for giving me the opportunity and spotting me among the dozens of participants. So, as usual, another nice show of different clinical cases which mimic cerebral palsy. And cerebral palsy is, to me, one of the most common neurological disorder in resource-limited and developing countries like in India, Pakistan, Bangladesh, Sri Lanka. Like we can say it's a disease of SAARC countries because for many reasons in the Western Hemisphere, the incidence is dramatically decreased over the past decades. Though still we see cerebral palsy in those countries, but that may be because of either some genetic reason or maybe significant birth events or maybe NICU graduate. However, the diversity of cases presented by different speakers, like starting from Javeria and subsequently like the last case, I think it's the nice show. And finally, the comments from the Biju and rest experts, including the Frida, which will be the as her comments. I think nothing left for me to conclude the session except that our youngsters, the budding pediatric neurologists, should be familiar with the etiology of cerebral palsy, because to me, cerebral palsy is an umbrella diagnosis which has dozens of underlying reasons which may be acquired or in some cases genetic. I still remember the talk a few months back delivered by Biju regarding the genetics of cerebral palsy. So that's why I'm wondering that there are many more insights in cerebral palsy, and our the young budding pediatric neurologist youngsters should be well familiar. So thanks for choosing this important topic, Shefali, and all the best in the coming weeks for this excellent evening masterclass, I would say. Thank you.
Thank you. Thank you. Thank you. Dr. Farida, you wanted to add for this case something?
Well, I would say all's well that ends well. Madhu definitely is leaving a mark on today's session, though it was the last case, but definitely a lot of food for thought. So thank you very much.
Thank you. So customary, I need to have take-home messages from all. So Dr. Biju, Dr. Brahim had to leave for some reason. So I mean, you are the chief.
I know you're going to ask me about I mean, what we have been discussing so far is essentially there are children with diagnosis of CP, and then you have a genetic diagnosis, and we talked about how it impacts one's identity, and is the shift from CP to genetic diagnosis is just a matter of semantics, or the question is like, does it essentially alter the individual's experience? Genetic diagnosis brings closure, no doubt, brings clarity, no doubt. But as I mentioned earlier, it can also disrupt the social narratives which are around the child. The problem is with classification, isn't it? Just like in epilepsy, we have definitions and classification. For epilepsy, we have changing classifications. And so medicine, although it is all based on biology, there is the social and the conceptual framework that we create, because CP means a lot. Everyone understands CP, even lay people, clinicians, families, everything, and they all understand CP, and they can visualize children with motor difficulties, children in wheelchairs, etc. And those boundaries are being challenged by these new genetic diagnoses, isn't it? And I think the categories, the medical classifications and definitions will also have to evolve as technology comes in, as new knowledge comes in, and the cultural understandings come in. We have to change. So CP can be looked at both ways. CP can be looked as a medical diagnosis, but CP can also be looked as a social construct, and which then adapts to new information. So as Mahesh was pointing out rightly earlier, yes, CP, which then people can picture CP, and then we gives a closure, we gives more clarity to it by our other test. There was a question earlier about spastic diplegia, monoplegia, quadriplegia. How does it matter? Perhaps the activity limitation, which might be better explained by GMFCS 1, 2, 3, or 4, or 5, which gives you a better idea of like what is the child. So in essence, I think the essence of CP does not lie in its cause, in the etiology. The essence of CP is in the lived experience of the child and experience of the carers. That's what I think. So, I'm sure
absolutely.
Forever and ever, but it is the lived experience what matters to the child and the family.
Yeah, that's important. But then also, if two things now with the genetic thing, that if something is coming up, that will help for this child sometimes with precision medicine, sometimes, and sometimes for genetic counseling. So in that way, it becomes important. And as Dr. Tipu was mentioning, but there is the prevalence of the incidence of CP has gone down, but there is not gone beyond a level because of for all the it's there. It's because of those extremely low birth weights on one side and the genetic and metabolic conditions on the other side. So that is going to constitute which is going to be there. So, Dr. Mahesh, would you like to say something?
CP mimics is going to be a growing field, and a lot of exciting information coming in the next couple of years with more genetic studies and more studies from different parts of the world. So it's going to change in the next couple of years. So CP is supposed to be a waste path analysis. Many people ignore this topic, but now it's going to take the front stage. So
no, that's a good point, Mahesh. Because the diagnosis is important, because otherwise it is going to mess up all the registries. All the CP registries will completely get messed up. All the epidemiological studies will get messed up, and there's no end to this. So there has to be some clarity as to yes, this is still CP. Otherwise, it's a disaster.
Absolutely, but I think we should not say it a waste paper basket. We should say a mixed bag. I mean, a bit humanistic touch. We had the humanism talk.
What I meant was most of meetings.
I'm just saying. I know. Yeah.
If you look at our program of any conference, ma'am, you hardly need talk on CP. Nobody talks about CP. So everybody thinks that nothing to be done in this field. But it's going to change
absolutely.
next couple of years.
Absolutely. Farida? Dr. Farida?
Yeah, I am totally in agreement with this, that nobody talks of CP. Once they get a diagnosis, at least I think.
Farida, 1 sec. Your take-home message is you're independent. You are not only in agreement with others, okay? That is very easy politically. You have to tell something fresh, okay?
Okay. So I have already given my take-home message. That CP is not exactly CP, it is genetic CP. Plus, it has to be acquired CP.
It is not. It may be genetic. It may be. Yeah, it may be. There may be a genetic cast.
So when you say maybe, it you give it an additional flavor, and then you start the wheels to shift and to think more. So then again, Mahesh comes in.
Yeah, no, thank you. Thank you all. I think we will wind up. It was very wonderful session with CP Mimics with so much diversity. So we welcome you all to the 70th AOCCN next year. And we'll abstract submission and symposia proposals is going to come on. And next week we come back with with Robin Whitney going to talk about TSC epilepsy and I think tuberous sclerosis with epilepsy. That is something very amazing and something very it's so much new coming up. So we expect you to come there next time. And the registrations are on. Can I have the slides, please? Or you want to directly go to the video? But anyway, registrations are on. You have the QR code. And those things have been mailed to you. They will be mailed to you again. But I think either you can, Asmita, you want to show the slides or the video, whatever you, anything. And then we might, yeah, the previous slide first. Yeah, previous slide. So you have the pre-conference on 16th and the conference workshop 17th to 20th. And you have the QR code on the next one for registrations, which are being mailed. I think video we had, you can anyway end up with the video. Thank you so much and see you next week. We can end with the videos, Asmita, or anybody wants to stay on to see and we stay on. Thank you so much. And thanks. Thank you very much, Dr. Biju. Thank you very much, Farida. And thank you all the presenters, and it's really, cannot hear you. Cannot hear the audio. Cannot hear the audio, Asmita. Audio is not heard. Asmita, audio is not heard.
Hello. What?
Yeah, audio was not heard. Yes.
Okay.
One second, while you're putting Shruti, you didn't give your take-home message, yeah? Shruti, you didn't give a take-home message, sorry. Huh?
No, it was a great learning for me. This like I have learned
some message. Thanks, thank you for moderating so well, and all the presenters are very good. Your certificates will be mailed to you. Asmita, something wrong with the technical?